Good afternoon and welcome to everybody who's joined us for this, our third in our hospital dentistry GIRFT webinars. I'm Liz Jones, I'm the clinical lead for hospital dentistry for GIRFT, and I'm delighted to join you to welcome you to this webinar about paediatric dentistry. Before I hand over to the clinicians who are going to actually host the webinar with me from GIRFT and Matthew Garrett from the faculty, I just want to say a couple of housekeeping issues. First of all, this is being recorded and the recording will be sent to everybody who's registered, whether or not you're joining us this afternoon live. Secondly, as the webinar goes on, if anybody has any questions for any of the panelists, please do put it in the Q&A box rather than the chat box. And we will endeavour to answer all the questions after the webinar if we don't get a chance in the Q&A, or we will answer them as themes depending on how many questions we get as we go through. As I said, the GIRFT project was one, or programme was one that was joint with the Faculty of Dental Surgery, and Matt Garrett as Dean has been very helpful throughout. But after Matt has said a few words of introduction, we will be handing over to clinicians, to BSPD and those that actually treat children actually live and in the trusts. And it's great that we've got somebody from community here also, Charlotte Waite. So without further ado, I will hand over to the Dean of Faculty, Matthew Garrett. Thanks, Matt.
Thank you very much, Liz. And I would just like to really echo Liz's warm welcome to this third series of webinars. The faculty were delighted to be involved in this programme and our ongoing work within it, particularly associated with the implementation of those priorities that we will talk about as the afternoon progresses. So welcome, and we look forward to a discussion at the end. It is my pleasure now to hand over to Sarah, who many of you will know, who will deliver her presentation. So thank you very much, Sarah.
Thank you, Matt, and thank you, Liz. A warm welcome to you all. If you didn't already know, my name is Sarah McCaig. I'm a consultant in paediatric dentistry and I work across two trusts. I work at Birmingham Children's Hospital and I also work within Birmingham Dental Hospital as part of Birmingham Community Healthcare Trust. And I guess that's when my story started, as I was invited to the deep dive visits that Liz, as lead for hospital dentistry for GIRFT, attended to do her exploration exercises. Following on from that, I was fortunate enough to meet with Liz as president of the BSPD. And I'm hoping that this afternoon that you will find what we have to say very useful. You will see from the agenda we have a wealth of experience and we are incredibly grateful to the speakers that we have here with us this afternoon. Sondos and myself are very grateful for Claire, James and Rachel to join us to explore their experiences, but also, as Liz has already mentioned, we have Charlotte Waite here as a senior community dentist and chair of the BDA England Community Dental Services Committee. It's my job, hopefully over the next 10 minutes, to look at the findings of the report, to highlight key recommendations and demonstrate how the report will support us as clinicians as we face the challenges of recovery, and ultimately support the safe and effective care for children and young people. I'm hoping prior to this event you've had an opportunity to read and digest some of the report and the recommendations. But hopefully this will give some consensus view on how we might take these recommendations forward. The NHS long-term plan promises a strong start in life for children and young people. And oral health and dental health is integral to this. When neglected, it can affect a child's and young person's ability to sleep, play, socialise, eat, and have a significant impact on the quality of life. Tooth decay is largely preventable, but to deal with these issues, we need a whole system approach focused on prevention involving primary and secondary care, schools, local authorities, and other agencies. So what did GIRF find? GIRF found that the burden of disease for children is unacceptably high. In 2018-19, there were 33,000 children under the age of 9 that had extractions in hospitals for tooth decay. 80% of these children, the diagnosis was recorded as tooth decay. There are significant inequalities in the provision of care and access to other treatment modalities. And for example, in some trusts, there's a lack of access to inhalation sedation. There are long waiting times with a massive variation between 52 days and 100 days. But some of the deep dive questionnaires reported that some trusts had up to a year of waiting lists. It's often longer for medically compromised children, and many of these children sit on waiting lists and having recurrent courses of antibiotics. In addition, it was recognised that treatment planning was suboptimal. Many acute trusts do not have specialists or consultants in paediatric dentistry. And much of the data is inaccurate due to the way that we are coding. So the GIRF process and the deep dive visits found common system-wide issues across all dental specialties and recurring challenges across different hospital trusts and across geographic areas. And so GIRF set the first recommendations across 3 main themes: understanding the work being done and by whom. And I'm very grateful for Sondos, who will explore this with us in our next presentation. Commissioning integrated patient pathways and the importance and the role of our managed clinical networks in terms of integrating those pathways. And Claire joins us to explore her experiences within those networks. And on the back of that, having the appropriate workforce that has the ability to move with the changing face of the environment that we are challenged with. And again, I welcome James and Rachel. In addition, we need to look with commissioners about how we manage those inter-trust referrals. So we can manage and we can appropriately see children in the right place, by the right person, in the right environment, in order to give them the appropriate care if they have a medical condition. So if we now look at the paediatric dental specific recommendations, the first, as part of measures to avoid repeat general anaesthetics, all children that require a general anaesthetic for dental extractions should be accompanied by a robust and appropriate treatment plan. Those dentists providing this who are not specialists must be aligned to a specialist-led paediatric MCN. And we need to consider ways of reducing the number of general anaesthetics and explore with our colleagues, for example, piggyback procedures and reduce the reliance on general anaesthesia for children. The second is around those children waiting for a general anaesthetic for extractions. There should be a clear aspiration that children at risk of infection should wait no more than 14 days from referral to treatment. And they should not be on waiting lists and being prescribed multiple courses of antibiotics. And the third, we need to use the strategies from the Children's Oral Health Improvement Programme Board and implement them at a provider and commissioner level. Children's oral health should be treated as a high priority and as part of the overall paediatric wellbeing agenda. And we need to be seen and round the table and be included in the work of the newly created paediatric surgery operational delivery networks, in order to support patient pathways and provision of care. So what does the report mean for clinicians? Well, we need to understand our services. Many of you will have already done a great deal of work in terms of validation, but we need to reduce those avoidable cancellations, and we can only do that by understanding what we have waiting, who is waiting, and how long they've been waiting for. We need to have robust treatment planning, and we need to be linking in with specialists in paediatric dentistry and have input and engage with our local managed clinical networks if you are not already. And we need to explore different ways of working. This may include exploring piggyback procedures and collaboration with our medical colleagues. It may be developing our inhalation sedation services or IV sedation services. But we need to embark on reducing the reliance on general anaesthetic. And most importantly, we need to ensure that our medical directors or chief medical officers have seen sight of the report. They have done, they know about it, and many of you will be part of those operational teams that will have had part of, will have explored this report locally. So what does it mean for those operational teams? You need to understand your workforce, you need to understand your service. We need to interrogate the waiting list and review how we're coding our patients and ensure that as most opportunities that we have, that we report on patients waiting dental extractions. You could do and you could support and help and develop solutions to improve access to general anaesthetics by prioritizing paediatric dental lists, remembering that these children invariably have been prescribed a general anaesthetic for dental extractions, having already had pain, swelling, infection, and may well have also had numerous courses of antibiotics. Many of your trusts may already have a community dental service under your umbrella, but there are community services that will not be under your umbrella, and you need to look at including those when prioritising dental lists. There is a need to establish the links with the managed clinical networks to promote and collaborative working, and at all costs champion paediatric oral health as a key concern at every system level. So in summary, the paediatric recommendations from GERFT was to avoid repeat general anaesthetic. We need to ensure that all children should have a specialist-led treatment plan. There needs to be a clear aspiration that children at risk of dental infection should not wait any longer than 14 days from referral to treatment. And ultimately, children's oral health should be a priority as part of the overall paediatric wellbeing agenda. I'm now going to move to Professor Sondos El-Badri, who will take us through the first recommendations for GERFT with respect to coding.
Thank you, Sarah. Thank you. So, as Sarah said, I'm currently the president of the British Society of Paediatric Dentistry. I'm also professor in paediatric dentistry at the University of Liverpool. And I, like Sarah, work across two trusts. So I work at the Dental Hospital as part of the Liverpool Foundation Hospital Trust, and at Alderhay Children's Hospital as well as part of my week. And I'm here to talk about the coding for paediatric dentistry and the progress made so far. So what does it mean? What does coding mean? And when Liz contacted me first around August, September time, when I just starting to take on the presidency term, I knew very little about coding, and I know much more about it now. And that's what probably I'm going to try to explain during my presentation. I knew that coding is really important. It's our way of all trusts nationally reporting their data and their information, and that is how we can actually then understand the work that is being done, which is the key important thing. We also need to understand the volume of work and who's actually doing it. And I'll come to that later in the presentation, but that is a really important part and important purpose of coding. This should then inform our service development. This will give us good quality data for workforce planning. And I can't be not talking about all that without putting my clinical academic hat and talk about research that is meaningful, that will affect patient directly and affect patient care. So it is quite important that we understand the coding. And if you read the general recommendation around coding in the GIRFT report and focus on those, and I'm going to only focus on the ones that are really glaring and focused for pediatric dentistry, but you won't find those into the pediatric dentistry recommendation. All these recommendations will be under the cross-specialty recommendation. The first one really was about how the specialty codes and treatment function codes do not reflect the current landscape of dentistry. And this is especially important for us in pediatric dentistry. And those colleagues who work in hospital trust, with the service might be under consultant from other specialties like oral surgery or OMFS. All these data will be recorded under the specialty that you're working under. So I'll put this table from the report, which I'll explain. So a specialty code, we do have a specialty code for pediatric dentistry, and we do have a treatment function code for pediatric dentistry. But it's mandated by NHS England that these specialty codes are actually linked to the consultant under which the treatment is actually done. And therefore, if you work in a trust as a specialty or a specialty dentist, or a community dentist, and your list comes under a consultant in MFS, then these data will be recorded as MFS, and therefore we won't be able to know how many children are being seen or being treated in a way without actually trying to analyze it by the age of the patient and the age of the child. So they do mean quite important for us. And the GIRFT recommendations are very clear, is we need to try to review those to make sure that the people who are actually doing the work and responsible for the work are actually being identified. I think this is work in progress because we will need to make sure that we're coding the important things. I had discussions with our coding service recently. About 10 years ago, I took over the extraction list and moved it from oral surgery to pediatric dentistry. And I found that until very recently, this activity is still being coded as oral surgery activity because of the historic of the coding. So it's really important that you actually try to understand that and try to unpick that. The next part of coding is what we call the OPCS for procedure, or what we call procedural codes. Now, these are a statistical classification for clinical coding that every hospital trust will have to report for hospital intervention and procedures. And again, the report has found that those are poorly defined and inconsistently applied in pediatric, in dentistry in general and in pediatric dentistry. I guess one thing you need to know, and how does it work for you? Do you actually write your record and somebody else code a specialist coder is coding it for you? Are you ticking those code lists? So all these codes are in a big book. And we have a chapter called Chapter F, which is a procedure of the mouth that we mainly use. And are we actually consistent in applying these codes? So are we using the same codes for the same procedure? How are we actually interpreting those? And the most important question is, do we have a code for everything we do? And that was the recommendation that was quite important, that we review those procedural code and we actually have clarity about them and what we do about them. So we had a very, very small working group, myself and Sarah and Helen Rogers from Newcastle. We had a very tight time scale, and our main purpose at that time was to try to review the current codes and identify any area that are not clearly coded. After that, we had to request some new codes for those areas that were not clearly coded. And we then had to actually identify and do a description of what they mean and define them, and also try to make sure that we have a justification for them. So we have put those codes forward for preformed metal crowns, for silver diamond fluoride, because we felt it's very different to fluoride, to fluoride varnish, pulpotomy, and we also worked with our restorative colleagues and felt that we need to further divide that into primary teeth and secondary teeth. And when we use it in secondary teeth, our restorative colleagues are using it more and more for posterior teeth to manage caries. We wanted to know if we're actually using it for anterior teeth in a case of trauma. And we have requested if we can divide that even further on by the actual teeth. Things like epixification, we couldn't find any code for that. And acclimatization, which we felt is a very important part of what we do as pediatric dentists on an everyday visit. And it's not actually being recognized or coded in the current coding system. We will not know the results for those until April this year, and we won't be able to use them until April 2023. But nevertheless, that's the progress so far. And the next part is we're going to try now to get a bigger working group, and we're going to reach out to other members of the society and the profession to try to define the current codes used in pediatric dentistry for consistency. So we're all talking about the same thing. The other part of the coding that came as a problem is hospitals are currently not mandated to record the type of anesthetic used in any setting. As Sarah has mentioned, we do a lot of inhalation sedation and sometimes IV sedation. And we actually don't know the volume of that. We don't know how much of our cases are general anesthetic or how much of them are inhalation sedation or local anesthetic. And we actually have made some progress on that, and now the classification service is going to ask Trust to record the type of anesthesia that is being used. So we actually hopefully will be able to distinguish between general anesthetic and sedation. Whether we can take it to inhalation sedation or IV sedation will be another matter, but at least we can identify sedation. And in children, in our case, the majority will be inhalation sedation. And that will be in response to the recommendation 2, which is the type of anesthetic used should be recorded and reported using the OPCS4 procedure code as part of the commissioning guide. So I guess in summary, really understand coding. One of my PhD students just had a long discussion as part of her thesis with a coder in Alder Hey, and we just understood how difficult and how complicated coding is. So it's really important that you actually understand coding and find out how activity are coded in your environment and how is and improve recording so we can end up with better data quality and understand our service better. And now I'm going to hand over to Professor Claire Stevens, CBE. Claire is a consultant honorary clinical professor in pediatric dentistry, and she is the MCN chair for Greater Manchester. All yours, Claire.
Thank you, Sondos. I hope everyone can see the slides there. Have you got my picture as well? If not, that's no great loss, I'm sure. So thank you, Sondos, for using practically every title that, that I have. Not necessary, I'm sure, but thank you. I have listed the different roles that I undertake here, although I think it's really important from the outset to say that I'm here to represent my own personal views and not of any employer or organisation that I work for. This is very much my own personal experience. So next slide, Adam, please. So I've put here to begin with a definition for a managed clinical network, more so for if you're looking over the slides at the end of this presentation. But what I wanted to get across here is that a managed clinical network is a linked group of health professionals and organisations working across primary, secondary and tertiary care, but in a coordinated manner and not restricted in any way by organisational boundaries. So when we come to work as part of a managed clinical network, We are there to act in the interests of our population rather than a particular provider who might well be our employer. Adam, next slide, please. So MCNs came about because of the publication of the commissioning standards as they were then. So the introductory guide, which is essentially an overarching guide, was published in 2015, and it outlined the need to have managed clinical networks in England. Subsequently, there have been specialty specific commissioning standards, including one for paediatric dentistry. Now, I put these here because although they are related to the commissioning of NHS dental services, and they are produced by the dental profession and overseen by commissioners and the Chief Dental Officer for England. So why would I be talking to you about a commissioner-facing document? Because as clinical leaders, we need to know the information that is being shared with our commissioning teams. We really need to build on the partnerships between clinical and commissioning teams in order to take things forward for our population. Next slide, please. So what is the role of an MCN? Well, we are there as local clinical leaders to inform commissioning decisions and to support our local dental networks, essentially to provide an expert but local voice. So we understand the needs of our local population. We're working across provider, across organisation to make sure the clinical voice is heard. You will be working with a range of stakeholders, so consultants in dental public health, as well as LDN chairs, Health Education England, lay reps, trainee reps, a wide range of individuals. And also, as Sarah mentioned in her first slides, there is now a relationship with organisational delivery networks, and I'll explain how this takes place. So MCNs are there to develop and operate to improve services, but how they will actually work will be a matter for local determination. So the MCNs, whilst having similar purpose across England, won't be uniform in their membership or how they operationalise those decisions, or even how often they meet. Next slide, please. So the role of the MCN chair is there to lead the MCN and to represent the MCN on regional dental leadership groups. And I was delighted to see that Adam Morby, who is the first regional chief dental officer to be appointed in England, is here on the call. And I would expect that he has good communication with his MCN chairs of all specialties. So I'll put a slide later on which shows how we used to run things in Greater Manchester. Again, there will be regional variation, but we need to make sure that that MCN voice is heard at a regional leadership group, but also that voice comes back. So the strategic direction of a regional dental leadership group is then shared with MCN members. So there should be admin support for this role that isn't in place nationally. Again, my personal opinion, but there needs to be, if we are serious about managed clinical networks, they need to be effective and funded and adequately supported. And every MCN should have a work plan and objectives and priorities which are agreed within that dental system leadership group or that regional dental leadership group and reporting into the LDN. Next slide, please. So membership, as I said, will be variable, but absolutely critical. There will need to be commissioner involvement. There will need to be clinical leads from all providers working across that geographical area. There absolutely must be dental public health representation and representation from all of the dental teams. So I would strongly advocate that there should be dental nurse and dental therapist, the whole oral health care team with an interest in children's oral health should have a visible presence and visible voice on this group. And also what I haven't put on this slide, but I think is critical, is having that lay voice. So even if you don't have a lay member on your MCN, because that is quite a challenge to achieve, and believe me, I have tried, you need to have a mechanism for ensuring that that lay voice is heard at every opportunity. And another one I haven't put on here is HEE as well, which have been absolutely critical to the success in GM. Next slide, please. So where are we nationally? And by that, I mean England, because that is my place of work, although I can talk about the devolved nations if there are further questions. essentially, in paediatric dentistry, we're at different stages of development. Some parts of England have had established MCNs for approaching 5, I think this is the 6th year for some now. Others are only just about to form, and there is one area without an established MCN. Some don't have an identified lead for paediatric dentistry, so historically they have been, paediatric dental MCNs have been merged, if you like, with special care dentistry MCNs, but our advice and sort of direction is that there should be dedicated MCNs for paediatric dentistry. So I hope it comes across that communication and collaboration is key. There is no point clinicians talking to clinicians, nothing significant in terms of dental system reform will happen if clinicians are talking in isolation. And I think it's something, you know, when I first started, I was told, well, this is your hobby. If you think it's important, you do it in your free time. Actually, I think it really needs to be supported. And one of the recommendations in the GIRFT report was to have effective and funded MCNs. Next slide, please. So this map, I'm hoping you can see it. You don't need, I'll talk you through the colour chart in case you're looking on a small device. This is 2 separate maps. One is April 2020 and one is November of last year. Sorry, April 21, I'm losing years. So what you can see on the left is the managed clinical networks as they were then. So red is no managed clinical network. And then going sort of progressively to the other side, green is a dedicated, so a paediatric dentistry only funded MCN, and then the yellow and orange are sort of the stages in between, so possibly funded but not dedicated, or unfunded and dedicated. And what you can see as we go from left to right is that we have got a lot more green, so there is good progress. And actually, even since this map, the red bit in the middle has now progressed as well. And the only red area is the northeastern Cumbria, who have a clinical reference group, I believe they call it, but it hasn't met for some time. But I'm delighted to hear only this week that that is about to get going again. So the plan is to hopefully see more and more green areas appearing. And what we've also done in a national role in which I'm acting clinical lead for the oral health team within the Children's and Young People Transformation team is we're beginning to actually coordinate these managed clinical network chairs into a forum. This is a clinician to clinician environment for networking, peer review and support, and sharing of good practice and lessons learned. So hopefully next time we talk, there will be even more green. Next slide, please. So I put a final couple of slides about ICSs. So for anyone that has managed to escape the ICS news, integrated care systems are new partnerships that assume their statutory responsibility in April this year. We still don't know exactly when they will begin to commission oral healthcare services, but I think that as a specialty, we need to be ready for when that time comes so that we can inform and influence the ICSs as they assume that responsibility. So I guess I have a degree of experience of this, having worked in a health and social care partnership, but I think it's really important that as a specialty, but also dentistry in a broader sense, is ready, coordinated, linked up, ready as a regional dental leadership system to inform those ICSs. Next step. Next slide, sorry. So how do we ensure it's heard? Well, I think there needs to be a connection of system leaders across a regional footprint. So for each of the NHS regions, there needs to be connectivity between the chairs of the managed clinical networks and between all of the stakeholders in oral health. And as part of that, the MCNs, I believe, have an increasing role in ensuring the voice for our specialty and for our children is heard. There needs to be communication at that regional level, but also I believe the managed clinical network chairs should be communicating at a national level so that we're not duplicating workload, and so that we can share good practice and spread that more rapidly. I think there will be specialty agreed priorities. I think that will come loud and clear, partly as a result of reports like GIRFT. And also, I think the managed clinical networks need to be working with the ICS clinical leads through this regional dental leadership system, with the organisational delivery networks who operationalise a lot of our intent, and who we have now connected all the managed clinical network chairs for paediatric dentistry with their ODM leads. And then, of course, because we're working with children and young people, we also have advocates in terms of the children's and young people regional leads, and we'll make those connections through the forum too. Next slide, please. So I put this here, not for you to read every box, but just to show you what the dental system leadership group looked like for Greater Manchester. There are a wide range of individuals, the managed clinical network chairs on the right, but also, as you'll see, Health Education England, commissioning teams, local authority teams, which are really important to have around the table, and significant primary care voice in our area. We call that the Dental Advisory Group. But you'll also see dental public health commissioners and operations teams, which really need to be working alongside these commissioners. Next slide, please. So these are not national priorities. These are the priorities of where I think we need to be for 2022. We could have a whole hour talking about waiting times for GA. How do I think that will happen? First of all, effective waiting list validation according to published national guidelines. Surgical prioritisation so that we are aligned to other surgical specialties. And now with the elective plan published by NHSEI yesterday, an agreement that there needs to be welfare checks and also an equitable recovery so that we are recovering our services and making them accessible to all. I do think there needs to be an upskilling and contractually enabling of child-friendly dental practices. If primary care doesn't work, then the system will be overloaded at secondary and tertiary care level. And we need to look after the most vulnerable in our population, including looked after children. Next slide, please. So finally, what are my thoughts? Well, it's in everyone's interest to have a strong MCN. It doesn't take over the commissioning voice. It's a strong partner to the commissioning voice. And it's only when those voices are all aligned that we can achieve the change that we're looking for. Those that put themselves forward need to be supported. We're taking on something new and we need the support of our colleagues and our employers. But actually, we also need to be mindful that we may be increasing the workload of our colleagues by attending meetings and our energies being diverted elsewhere. And finally, we need to work collaboratively, locally, regionally, as well as nationally. Thank you. I'm going to hand over to James now, who's going to do a double act, I think, with Rachel. Thank you.
Thank you, Claire. Hello, everybody. My name's James Spencer. I'm postgraduate dental dean in Yorkshire and the Humber. I'm an orthodontist by background, so I've got a slight degree of imposter syndrome today. As you've heard from Claire, the workforce within paediatric dentistry is quite diverse, and it involves those who are in primary care, dental care professionals, general dentists. It involves the community dental services. It involves specialists, and it involves the consultant workforce. And these should all be looked after by a functioning managed clinical network, which we do have in Yorkshire and the Humber. Prior to becoming a postgraduate dean, I was associate dean looking after specialty training, and we introduced innovative training within paediatric dentistry, which I'm going to share with you later. But the context of this is the issues that we have within paediatric dentistry, including the increase in waiting times and the inequality in terms of the distribution of specialty workforce. I don't know if you can just go back one slide, please, Rachel. So the GIRF report does reference workforce and training, and it says that we should actually review that and look at the future needs of the changing and aging population in each location. So obviously within the realms of paediatric dentistry is what is going on with our child population and what they require. Next slide, please. The context from Health Education England's perspective is that we have recently published the Advancing Dental Care Review, and this has now morphed into the Dental Education Reform Programme. And I'm going to share with you some of the recommendations. But what it is a blueprint for how we should be structuring our future workforce to actually deliver comprehensive and appropriate oral health care for our population. There were 20 actions and recommendations within the Advancing Dental Care Review. And the ones that are pertinent today, I think, are the ones around training, that we should have greater opportunity for flexible and part-time training for all our workforce, that we should have the equitable distribution of posts, training commissions from Health Education England's perspective. One of the innovative things that we've recommended is the development of centres for dental development. So what these are sites that aren't well served at the moment, that will potentially allow the structures that have been described by Claire in terms of managed clinical network and the layers of care that may be required to be developed where access to that care is currently poor. And what is also been recommended is the training linked to level 2 accreditation. And this is so that pressure is taken off the specialist and services that are out there. Next slide, please. So what we know from the data that we've accrued is that there is a significant uneven distribution of consultant and specialist workforce, and that currently it is mainly focused on secondary care environments in many areas. 44% of current training posts within specialist dentistry are in London, and 50% of consultants and specialists are in London. And I think we'd all agree that that is not the most appropriate way that we actually distribute our workforce. And this uneven distribution of training posts actually cements this and leads on to this. So what we're trying to do in terms of our solutions is to increase the number of specialty training posts in areas of poor provision. And to do this, we're seeking increased funding from Health Education England and NHSEI to actually allow us to do that. One of the barriers to that, though, that we have to recognise is the infrastructure and training framework that is required. We don't have a vast number of empty surgeries out there where we can look at put trainees and look after patients, and we have a very, very busy and pressurized training workforce who perhaps don't have the time to be able to deliver this training. One of the other things that we are seeking to do, and Rachel will cover this after myself, is to develop level 2 practitioners to take this pressure off our specialist services. Next slide, please. So when I was Associate Dean, and even before my time, the paediatric dentistry cohort that were in Yorkshire and the Humber were very, very innovative in thinking about how they could tackle some of these inequalities. And what they did was they went out to community dental services. They reached out and said, could you train some of our specialty trainees? And Rachel was actually one of the first ones who did this. So the 2 yellow dots are our teaching hospitals. Historically, this is where specialist departments are and where consultants will reside. But in actual fact, through the placement of specialty trainees who then became specialists and then post-CCST trainees, we have developed a network where we have a significant number of consultant-led primary care services. The red dots are where we have consultant-led services. So that's in Hull, York, Harrogate, Bradford, Wakefield, Doncaster, and in the community in Sheffield. Historically, we also had that in the community in Leeds. And what this does is allow the patients in the local community to be treated by the full range of professionals that need to be involved in their care. This took a lot of persuasion, but once these trainees and these specialists were in the services, I've got to say they are very much appreciated because of the service that they deliver, the high quality care that they can actually deliver to patients. And so this is a great way of taking off, one, developing great services for children, but also take the pressure off those more traditional places where specialist and consultant services are. Part of the solution is also level 2, and I'm now going to hand over to Rachel, who's going to take you through our development of level 2.
Thank you, James. So good afternoon, everybody. I'm a consultant in paediatric dentistry based in mid-Yorkshire, but also here with my HE hat on as the lead for the level 2 programme, which we have developed here in Yorkshire and Humber. My slide doesn't want to carry on. Adam, are you able to share that? For some reason it stopped allowing me to move on. So just whilst we sort that out, I'll just talk to you a little bit about the level 2 practitioner. We know it's not a new thing, it's been talked about for a long time. In 2002, NHS Dentistry Options for Change talked about planned development of additional skills for practitioners. And we've had DIPSIs and we've had DWESIs, but actually nothing has really ever taken off for paediatric dentistry. So a level 2 practitioner refers to procedural patient complexity care, which is delivered by dental practitioners who have enhanced skills or experience. Skills beyond the competency level of a GDP, but not at the level of a registered specialist. And these level 2 practitioners would have needed to have completed dental foundation training. Next slide, please. So in Yorkshire and Humber, we've developed a level 2 complexity care training programme. It's a 24-month programme which is funded by HEE Yorkshire and Humber. It commenced in January of 2021 with our first cohort, and we've started the second cohort last month. So in total at the moment, we've got 24 participants in the programme, 5 of which are hospital dental service dentists, 13 CDS dentists, 2 which are CDS and GDPs, so do part-time in each, and 4 GDPs. Next slide, please. So how does it all begin? Well, in June 2020, I sent letters to all the Yorkshire and Humber CDS clinical directors and heads of department at LDI and Charles Clifford Dental Hospital, asking for informal expressions of interest. We had 17 expressions of interest from CDS and hospital dental service dentists from Yorkshire and Humber, and 18 from outside of Yorkshire and Humber. So somehow the word got out, even though I'd only sent the letter within Yorkshire and Humber. And we were then inundated with expressions of interest from GDPs. So in order to narrow it down, we had to just approach the practices in the areas of high dental need. And in the end, we ended up having 10 formal expressions of interest from GDPs. The applications were ranked by representatives from HEE, the MCN and the LDN, and then places were offered, ensuring a wide geographical spread. Next slide, please. So what are the programme requirements? Well, each participant has to engage with an allocated mentor who will be a consultant or specialist in paediatric dentistry. They attend 1 supervised session per fortnight in a specialist paediatric dentistry setting. And they are required to attend the programme induction and then 10 study days. Next slide, please. The structure of the programme is that they have to complete a logbook. We ask them to complete reflections, but write up 3 reflections per year. They do 8 to 10 case studies of level 2 paediatric patients, and they complete 24 work-based assessments. They have 3 mentor meetings a year, and during their programme, we ask them to complete at least 1 paediatric dentistry-related audit or clinical governance project. And they also complete a multi-source feedback, which is colleague, and then a separate one for patient and carer feedback. Next. What we made clear to everyone at the very beginning is that it is not the remit of HEE Yorkshire and Humber to accredit participants completing the programme as level 2 practitioners. It's not in their gift. The accreditation process lies with the NHS commissioners in conjunction with the MCN. Completion of our programme will purely facilitate the application for the accreditation process by allowing the participants to put together a really robust and comprehensive portfolio. Next slide, please. Thank you. So where are we now? We've got the 2 cohorts running and we have 24 participants. So far, we've had absolutely excellent feedback on all the study days, not only from the participants, but also from the speakers. They're a really great bunch of dentists we've got on the programme. And we're collecting data, looking at the participants' current knowledge, what they're currently doing and their confidence levels. So the first cohort completed that on day 1 and have just completed it again at 12 months. And the second cohort have completed it at day 1. So we'll continue to collect that data. And having had a look briefly at the data from day 1 and 12 months, confidence levels, the amount they're doing and knowledge has increased across all the domains. Next slide, please. So where do we want to be? Blue sky thinking maybe, but hopefully quite realistic. We want all our participants to be awarded level 2 accreditation. We want the accredited GDPs to be issued with level 2 paediatric dentistry contracts. This thereby relieving the pressures on specialist services. We'd like to see similar programmes developed elsewhere in the country. There is a programme going on down south already, but as far as I'm aware, there's just the 2 programmes running at the moment. And bringing it back to GIRFT, we want children to see the right clinician and get the right treatment first time. Thank you. So I'm going to now hand back over to Sarah. Thank you, Sarah.
Thank you, Rachel. Thank you, James. Thank you, Claire and Sondos. I would hope that delegates have found the topics that we've covered incredibly useful in terms of an explanation and for the GIRFT report. Claire, sorry, Charlotte, I've got there's some questions that have come through the chat, but I think it would probably be important just to bring Charlotte in at this stage, because there has been some discussion. It came in the chats rather than the Q&A, but about numbers, and I suspect they're sort of about numbers of children that are coming through for general anaesthetic within the community dental services and they're not being captured. I just wondered if you wouldn't mind commenting.
Yeah, so certainly that's a concern, and that's something that we've raised over the years, and I think that the GIRFT is going to give us even more evidence to say that this needs to be sorted out. If you indulge me, I did prepare a little bit on CDS implications of GIRFT, and if I can whiz through that, that might help cover some of it as well. Thanks for the invitation to sit on the panel, and I just very quickly wanted to say thank you to everyone who's the dental team members who've come and taken the time to listen this afternoon, because it's been really tough for everyone. And I know that everyone's working really hard, supporting each other, supporting their services and supporting their patients. But it feels like we're in the next stage of recovery. And I think that the recommendations within the GIRFT are going to need to underpin what was announced, as Claire said, in the elective recovery plan yesterday. But what I'm not clear at the moment for the CDS is where GA elective services for CDS sit within this plan, and that's going to need to be clarified. It's very welcome to see the exploration of the CDS services within the GIRFT report, and indeed some of the recommendations apply directly to CDS. My feeling is that robust data is going to need to be gathered around waiting lists, and I know that there's work going on around that, but we're not going to be able to recover and plan recovery and understand the needs of the services, the needs of our patients, if the robust data is not available. In recommendation 11, we look at the aspiration to bring assessment to treatment for GA to 14 days, and I know that that's come up in the chat as well, and it talks about the working group being established to come up with strategies and solutions to access GA facilities and to reduce the waiting times. And I know that it's one of the huge concerns that CDS providers have, is the access to theatre space at the moment. It also says that we need data to be reviewed and collected if we're to avoid inequalities widening, which we know is all a big concern, but there is significant regional variation. It's been talked about the coding recommendations, and these are really relevant to CDS as well. I'm very mindful that, as was discussed, I think Sondos said, we're probably being coded under different there is recognition for joint procedures, which I know that lots of community dental services do. We're very holistic in our care, and I'm really glad that the GIRFT gives again that evidence to say that this is really good practice when there's pressures on clinicians' time to be able to say, look, this is what we should be doing, I think is ideal. And I'm glad that the GIRFT recognises that paediatric dentistry is delivered by CDSs, but that there is variation from area to area, and it says that it's not always clear what's included in CDSs. Clearly, there's further work to be done to investigate the variations of CDS provision, the contracting arrangements and the referral processes. And just to say that clearly there's work to do. There needs to be appropriate support for CDSs to continue in this phase of restoration and recovery. But I think working closely with the MCNs, working across the specialty, will help the profession, specialist societies, commissioners and providers work together to meet the GIRFT recommendations. So it's just some of my thoughts on CDS. Thank you.
Thank you, Charlotte. And I think that it's incredibly useful having you here, and because I think I think you've underpinned a lot of concerns that people had in terms of how GIRFT would influence the community dental services. I know we are a little bit short on time, and there were a number of questions. Claire, I'm coming to you about MCNs, and initially one of the concern was who is funding them, and why do some still remain unfunded, and how do areas seek to level that playing field? And I think people would quite like some, and I suppose linking in with that, there's thoughts about, or your thoughts about how MCNs may embark on remote team working in order to support services that may not have specialists but want to align to an MCN, and whether or not there's any additional resource to support that.
Okay, loads of questions there. I'll try and answer them as quickly as I can. It's all right. So the degree of funding of MCNs is variable. So some of those MCNs that are green might be funded as little as one session, one PA every month. Personal opinion, that's inadequate. Some are funded up to 2 PAs, so 1 day a week. Where does the funding come from? Again, there is differences. In many areas, this is regional NHSEI commissioners that are funding the MCNs, but in some places it is funded within a job plan of a consultant that's working in a trust, and there is an agreement with the regional team to support the MCNs. Ultimately, I think there needs to be an agreement on to how to actually recognise the MCN chair's time, but also those involved in the MCN. The second question about remote support, I'm not aware of any plans, but I think that it's something we're going to have to embrace. And actually, I think if there's something positive to come out of the pandemic, it's that this remote way of learning is more acceptable. So, for example, I'm now providing support to a regional commissioning team, which is nowhere near where I work or live geographically, but actually with this connectivity, that support is possible. So absolutely, I think it's something we should support. That peer support is absolutely critical, and I don't think any longer it has to come from someone that's just down the road. I think there's other ways of joining up and providing that support to make sure that everyone is engaged with the MCN, even if they are working in rural areas.
Sarah, I'm going to butt in here because I see that the clock says 16:59 and we've got to, well, we've agreed to finish at 5.
I know.
But actually, it's extraordinary. We could just go on and on, and we could have another hour on this. So this has been a really, really, really good session. Thank you so much to all the contributors. Just a couple of very quickly, I'm hoping that GIRFT will be able to look at the CDS, Charlotte, because I do think that's the interim bit between primary care and secondary care, and it's a missing link and terribly important link. So that's 1. 2, brilliant about the MCNs, and let's really work to get them effective and functional. And I think the level 2 stuff is absolutely fascinating. And I saw in the chat somebody say, well, where are these level 2? I want an opportunity. If we can get more paediatric dentistry done in primary care, that will be a huge step forward, won't it? And I think the GA sedation thing, at least having some numbers around that, so we know what's happening to children will be really critical. So I think we're making good progress. Thanks to Sondos, Sarah, for being on the working group. Thanks to Rachel and James for putting forward the level 2 stuff. Claire for amazing work on the MCNs already, and it's a bit of a, you know, you're setting the scene for other specialties to actually map their MCNs. And Charlotte, watch this space, because with any luck, we'll be looking at the CDS and we'll want your help. Thanks, Matt, too, being the Dean and very supportive. Thanks very much, everybody, and have a fabulous evening. Take care. Thank you.